On to our third speaker. Our speaker, Dr. Zarina Zahari, who graduated with Doctor of Philosophy in Physiotherapy from UITM, a Master Health Sciences Research from UITM, and Bachelor of Science, Honours Applied Rehabilitation Physiotherapy from University of Teesside, UK. Formerly, she worked as physiotherapy at Pusat Perubatan Istimlaya in 1998, and she joined UITM till now as lecturer at the Center of Physiotherapy Studies. And her research interests include studies on low back pain, musculoskeletal physiotherapy, rehabilitation, pain management, patient education, and clinical education. To date, she has published papers in various national and international journals, and Dr. Zarina has also been a loyal member to Malaysian Physiotherapy Association since 1998. Without further ado, I would like to welcome our final speaker for today, our last speaker for today, Dr. Zarina Zahari. Dr. Zarina, the floor is yours.
All right. Thank you very much, Dr. Ida, for brief intro of myself. Yeah. And Assalamualaikum and very good day to everyone, to all the participants. Yeah. Thank you for joining us today. And this is the last session for today. And I am Dr. Zarina Zahari, Senior Lecturer in Center of Physiotherapy, UITM Puncak Alam. And today I will share with you on the topics of strategies in managing patients with chronic low back pain. Okay. Can you see my slide?
Yes, it's coming up.
It's coming up.
Okay.
All right. Okay. All right, strategies in managing patients with chronic low back pain. I know that there are many of us are having low back pain too. Yeah, it's not only the patients, and we also can become the patients as well. Okay, instead of the therapies that managing the low back pain. All right, here are the contents that I will include in my sharing today. And as what we know, low back pain is such a very global burden. It gives a big burden to the world. And as what we know that it is the number one cause for disability in high income and middle income countries. Okay, and in fact, about 80 to 85% of people over their lifetime, and most of acute low back pain improve rapidly. However, there are 4 to 25%, turns out to be chronic low back pain. And the prevalence of chronic low back pain was about 13 to 20% among people, in 18 years old and above. And in Brazil, there are 25% of their older population that having chronic low back pain. Yeah, and the prevalence keep increasing in Brazil. Yeah, recently, and it reached about 42%. Yeah, and studies have found that chronic low back pain occurs more among the female compared to the male. Yeah. And in Malaysia itself, the prevalence of low back pain range from 26% to 63% among people aged more than 18 years old. Okay, and this varies in different occupations and different age of people. Yeah. However, there are still limited studies on low back pain, and especially on chronic low back pain in Malaysia. So it is a great need actually, to do research on low back pain, especially in terms of low back pain management, and very, very limited information on systematic reviews regarding the chronic low back pain in Malaysia. Okay. Here are the statistics. On the left side is about the low back pain statistics, the recent one in the US. Okay. This study, from this statistic, they found that 85% of patients tried at least one treatment for back pain, and 68% haven't discussed about their back pain with the doctors, and 50% of most people say that their pain remain the same, though they have had the treatment. Yeah, and 80% of them reported severe pain. Yeah, so this shows it is very, very high in percentage in people with low back pain. Yeah. And when we look at the global comparison of prevalence rates of low back pain and the general population of developed and developing countries, we can see that there are increasing prevalence, yeah, from Germany and up to United States. And currently, it is very, very limited literature reviews looking at the prevalence, especially the systematic reviews. Yeah. All right. What is low back pain? Yeah. Low back pain can be defined as pain and discomfort localized below the costal margin and above the inferior gluteal folds, with or without referred leg pain. While the chronic low back pain is defined as low back pain which exists for at least 12 weeks or even longer. And in most of cases, chronic low back pain is defined as the persistent pain that exists longer than 12 weeks, all right? Okay, here are the classifications of low back pain. Most of the time, you see that patient comes to you with acute low back pain, subacute low back pain, and also chronic low back pain. Okay, for acute low back pain, pain persists in less than 6 weeks. Okay, for subacute, most of the time, patient come with pain within 6 to 12 weeks. However, for chronic low back pain, again, pain exists beyond 12 weeks. Yeah, and you also may find there are some other classifications where it goes by the seriousness of the pathology, right? For instance, the red flags or the serious medical issues, yeah, like serious spinal pathology, for example, infection, malignancy, fracture, and inflammatory, that comes under the red flag of serious pathology. Yeah, and the nerve root pain, yeah, which related to radiculopathy. Yeah, it could be sciatica, it could be any facet joints related to radiculopathy, and etc. and etc. Okay, and this may take 2 months, yeah, at least for the symptoms to resolve. Okay, and the very common one is non-specific low back pain. Okay, this is often triggered by a minor sprain or strain of the back, and most of the times it could be mechanical, which worsen by certain movement or the postures. Okay, and pain usually improve within 2 weeks, but if it lasts longer or beyond 12 weeks, it turns out to become the chronic low back pain. All right, here are the stages of low back pain. Okay. When we say acute low back pain, most of the time it comes in a single episode and it's going to resolve in 6 to 7 weeks. Okay. If it is not resolved after 7 weeks, then it turns into subacute low back pain. Okay. Under subacute, it most of the time resolve between 7 to 12 weeks. Okay. And if this beyond that, it turns out to become the chronic. Okay, so you can see the stages there, right? From acute, it shifts to subacute and even longer in the chronic low back pain. All right, acute versus chronic low back pain. Here you must be very, very clear. All right, what is acute low back pain? What is chronic low back pain? Today, for this particular session, we are going to discuss about the chronic low back pain. Okay, not the acute low back pain. All right, acute low back pain, yeah, meaning that pain lasts within 4 to 12 weeks, right? And most of the time it heals on its own, yeah? And there is no lasting pain or there is no serious impairment, okay? However, in chronic low back pain, yeah, pain lasts even longer, more than 12 weeks, and even it's persistent there, okay? Persistently there with some other associated factors. All right, differential diagnosis of chronic low back pain. Okay, you can Google, you can search from the reference that I give you there. Yeah. So for differential diagnosis, basically, you should have a differential diagnosis on non-specific or idiopathic pain. Yeah. And compare it with the chronic low back pain. Yeah, you also should look at the mechanical. Yeah, and most of the time it's about 27% of people that present to you having mechanical problem. Okay, and referred pain, which is less, about 2%, and non-mechanical is about 1%. Okay, what are the causes of pain in the back? Okay, it is most common that you see in your clinic that patient comes to you with degenerative changes. Yeah, instability, organic problem. Yeah, nerve compression or irritation, or sometimes yeah they have some facet joint problem, which leads to compression onto the nerve roots. Yeah, and also rule out some psychogenic cause like insurance claim, but in Malaysia scenario it's not much on the insurance claim. Yeah, however, in the US and the Europe, yeah, most of the patient comes or turn to the clinic because of this issue. Yeah, and also problems with the employer and etc. Okay, here are also common causes of low back pain, where you can see that degenerative and spondylosis may occur in people with age more than 40 years with mechanical pain, and also with some associated pain in the calf. Yeah, and a spondylolisthesis, yeah, can occur in people younger than 20 years old or even older than 40 years old. Yeah, it could also be due to mechanical pain. Yeah, or mechanical sources. Yeah, and most of the time spondylolisthesis is associated with extension or hyperextension activity of the spine. Yeah, in trauma can occur at any age. Yeah, if you have the MVA, if you have any falls, yeah, that causing some trauma or injury onto your spinal structures, it can lead to pain as well. Yeah, and infection also can occur at any age, and infection can be from TB. Yeah, tuberculosis of the spine and anything septic and so on. Okay, and also metabolics. Yeah, metabolics is most of the time affect people older than 50 years old, which is more of non-mechanical. Yeah, and osteoporosis. Osteoporosis is very common among the elderly age more than 60 years old, and it is more of mechanical issues here. Okay, what are the risk factors? Increasing age. Yeah. But currently, we found that there are increased prevalence when there is increasing age. Why? Because of increase in the population, older population in the world. Okay, smoking is another factor. Muscle weakness in the back and or abdomen, psychosocial factors, stress, anxiety, occupational factors, overweight, repetitive lifting, chronic steroid use, and also the sedentary lifestyles. Okay, nowadays during the MCO, there are plenty of people complaining of low back pain because of sedentary lifestyle. Okay. And here are common clinical presentations. For chronic low back pain, yeah, there are people that comes to you with red flags, yeah, but there are more people that comes to you with yellow flags. Okay, identify all the red flags, yeah, and also the yellow flags. Red flags, you can got it from patient history, yeah, or from history about their present, past, and also past medical history. So patient will tell you the histories there, so you can identify whether they are red flags or not. Yeah, and the medication history, the sign and symptoms, and most of the time these people having unexplained weight loss. Okay, and also night sweats and inflammatory back pains and so on and so forth. All right, the yellow flags is big concern or main concern in those that having chronic low back pain, right? And here with yellow flags, yeah, you should identify the high baseline pain and disability. Okay, how much is their pain? Yeah, what cause of their pain, how much disability that they face. Yeah, is there any sleeping problems, depression, anxiety, pain, catastrophizing, work environment, yeah, and poor social support, and also related with low socioeconomic status, and also general health related issues. Yeah, fear, irritability, yeah, and reduced perceived control over one's life. Okay, with the current MCO, there are plenty of these issues. Yeah. All right, what happened actually? Okay, in the first 2 months, yeah, this patient is categorized under phase 1. Okay, so during this phase 1, they still have the active coping. They still know what helps to reduce their pain and so on. Okay, they know what to do when they have pain. Okay, believe that pain is controllable, and increased physiological arousal and anxiety is quite common at this particular phase. Okay, then within 2 to 6 months, yeah, that's during the second phase. In the second phase, yeah, they try to test of different coping styles, okay, whether from active management or from passive management. Okay, varies between increased and decreased activity. What happened? They try to test all this, yeah, and at this particular time, depression may occur. Okay. Why? Because some of them able to find the coping strategies. However, there are some that cannot cope well. Okay, so depression may occur. Yeah, and after that, it progressed to 6 to 24 months. This is during the phase 3. Yeah, at this particular time, yeah, hope of a cure is reduced. Yeah, maybe they feel like, oh, it is useless, you know, for their lives to have a persistent pain, which is not cured. Yeah, though they take plenty of medications with a lot of prescriptions from the doctors. Yeah, but their pain or their problem is not resolved. Yeah, and they found that their activity become less. Yeah, problems with pain medication may occur, and believe that pain is uncontrollable. Tendency towards passive coping strategies. They try to find out any other alternative ways, yeah, to cope. Yeah, and depression is very, very common in this particular phase, and focus on bodily complaints, like, oh, I have pain here and there. Yeah, everywhere is painful in my body. Yeah, they always complain of that. Oh, everywhere is pain. When you ask them, oh, can you tell me where is your pain? Oh no, I feel pain everywhere. I cannot tolerate with all this pain. Yeah, these are the presentations that they help you. Yeah. So you need to know about pathobiological mechanism of the pain when people tell you about the pain. Okay, remember there are 3 pathobiological mechanisms that you must know. Okay, the first one is nociceptive pain. Nociceptive is always related to nociceptors. Okay, nociceptive, yeah, can be divided into inflammation nociceptive or mechanical nociceptive. Okay, so yeah, for example, in here is in OA, ankle sprain, rheumatoid arthritis. So here, the nociceptive are working, that sending all the info to your brain to tell you, oh yeah, there is inflammation, so the pain should be there. Okay. In nociplastic, yeah, is about the central processing. Long time ago, we used the term central mechanism, okay? But recently it changed to nociplastic, yeah? And here it involved the central system in our body, yeah, the brain, the spinal cord, yeah? And here, in this category, there will be increase in excitability, yeah, or reduce in inhibition. In central pain processing, it's more of sensitivity, yeah. It's not more of nociceptors, but it's more of sensitivity here, yeah. For example, in fibromyalgia, in TMJ patients of the MD, yeah, and also in non-specific low back pain, they can say that, oh yeah, my pain is everywhere. My pain is there all the time. Okay, That because it is probably increased excitability and reduce low inhibition, yeah, to block the pain. And lastly is neuropathic. Neuropathic is always involved the nerve. Yeah, most of the time is the peripheral nerve. Okay, it always related to any radicular pain. Yeah, yeah, any reflex pain. Yeah. All right. When you have nociception, okay, it always associated or related to social cultural, also related to biological or physical, and also related to psychological. Okay, in social culture, just anything that related to social activities or social communication or any related to social are involved in here because the patient is having pain, right? Okay, and in biological, physical, yeah, most of the times it's related to the genetics, yeah, the sex, nervous system characteristics, yeah, the sleep, the age, and it will cause pain. Yeah, biological is most of the time physical injury, which involve the physical trauma or physical structures in our body. Okay. And another factor is psychological. Psychological is emotion. Okay, emotion. Yeah, remember pain, we have the physical pain and we have the emotional pain. Yeah. Psychological is always involved the emotional pain. Yeah. Here it involves with feeling. Yeah. Depression, anxiety, all the coping skills, yeah, just name it. The cognitive, emotion, yeah, all the negative attitudes or fears, yeah, comes under this category. Okay, when you have this part, these factors, it will cause suffering. Okay, so nociception, yeah, leads to pain, leads to suffering. It will give effects, okay, to the physical, to the psychological, and also to the social. Okay, so it will alter the whole system in a person, in human being. That's why, in terms of management, we should think and we should apply the biopsychosocial approach. All right, especially to cater the chronic condition. All right, and you can search for the referral that I share there. All right. Okay. What are the evidence reviews or recommendations for the management of chronic low back pain? All right. Few guidelines exist in the management of chronic low back pain. You can search it in the Google, okay, or in the webs or anywhere, okay. There are plenty of them. All right, and bear in mind that back pain is not a diagnosis, okay. It's just a symptom of pain. Where is the pain? It's in the back, okay. It's not the diagnosis. Yeah. And patients have different stages of impairment, disability, and chronicity. Not all patients come to you with similar problem. Okay, they will tell you different problem, different sensitivity, different history, different, everything is different. Okay, and overall, there is limited positive evidence for therapies in patients with non-specific chronic low back pain. Okay, there are plenty about the management of acute care or subacute, but it's a bit limited on the specifically on the chronic, yeah, and it is hardly treated on non-specific chronic low back pain. And for most therapeutic procedures, yeah, they found that the effect size are rather modest, okay, very small. Okay. And in cases of low impairment and disability, simple evidence-based therapies encouraging activity or exercise, yeah, brief cognitive behavioral interventions and medication may be sufficient, okay, in certain cases, yeah, in a less serious condition, okay. However, it does not really work. There's not much evidence to show effectiveness on the serious or severe chronic low back pain cases. And no single intervention is likely to be effective in treating the overall problem of chronic low back pain of longer duration, or even in a more disabled care, or owing to its multidisciplinary nature. Okay, here Okay, 10 back facts that you must know. Okay, we need to change all these things. Yeah. All right, according to O'Sullivan et al., 2019, okay, there are 10 facts. The first one is about persistent back pain can be scary, but it's rarely dangerous. Yeah, when you listen to your patient saying that, oh, I am having that back pain for, more than 2 years, but it's still there. The pain is persistently there. It does not change. Bear in mind, it's just a pain, but it does not show any danger. Okay, why? Yeah, and it not lead you to the wheelchair bound person. Okay, still able to walk. Okay, unless if you have some good or evidence that it prove, oh yeah, this is due to a physical problem or biological problem that you need to fix that. Okay, but if it is non-specific, there are some other things, some other factors that trigger the pain. Yeah, but it is not life-threatening. Okay. Point number 2, getting older is not a cause of back pain. You know that, most elderly in the world, they are very active. Unless is they, really go into sedentary or, apply very, very less or minimal activity in their young, then only, they tend to go into slow or low physical activity at their older age. Yeah. And the third point, persistent back pain is rarely associated with serious tissue damage. Okay, bear in mind, it is not of tissue damage. Okay, especially in non-specific low back pain. There are other factors like stress, tension, fatigue, inactivity, accustomed activity, yeah, which make back sensitive to movement and loading, especially in the current scenario of a lot of open learning distance or sedentary lifestyle, which leads you to inactivity. Okay. The fourth point, scans rarely show the cause of back pain. Okay. In most cases, if acute case, yes, you can see in the scans, yeah. Oh yeah, the disc is protruded. Okay. Oh yeah, they are reducing in space and so on, so on. However, in non-specific low back pain, it is not. Okay, you cannot see that, yeah. And fifth point, pain with exercise and movement doesn't mean you are doing harm. Okay, remember here, pain, always remember, pain is not equal to harm. Pain does not lead you to harm. You must educate your patient into this. Okay, pain is not causing harm. Okay, next point, back pain is not caused by poor posture. Okay, how is it stand bend does not cause back pain? Yeah, even though these activities may be painful. Yeah, just continue. Yeah, maybe alteration in certain postures helps you to relax. Yeah, and it helps you to reduce the tension in the back. Yeah. Point number 7, back pain is not caused by weak core. Okay, bear in mind, core, what does core muscles do? Yeah, yeah, it helps to protect the whole spine there. Yeah. All right, backs. Point number 8, backs do not wear out with everyday loading and bending. Bear in mind, your spine is very, very strong. The ligaments surrounding the spine, the muscles surrounding the spines are very, very strong. Okay, so they hardly or rarely get injured easily. Okay, pain flares up don't mean you are damaging yourself. Again, remember here. Okay, pain flare up can be painful, okay, and scary, but it does not mean there is tissue damage. There may be some other factors that trigger the flare up, okay. So helps to stay calm, reduce the stress, and probably it helps you. Okay, the last point here: injection, surgery, and strong drugs usually aren't a cure. Okay, it's not cure your problem. Yeah. All right, roadmaps to managing pleasant with musculoskeletal pain. Okay.
Dr. Zarina, we have more minutes.
All right. Okay. The first one, screen for serious pathology, biopsychosocial risk factors, and health comorbidities. Okay. Here, you must exclude serious pathology, identify targets by psychological, social drivers, pain and disability, embrace patient-centered communication, listen, yeah, open and reflect questioning, yeah, to elicit patients' understanding of pain experience. How do they understand about their pain and their problem? What's their belief? What's their concern? And what's their goal? Okay, use all those information in your strategies. Okay, the third point, educate beyond words using active learning approaches. Okay, include more of education. Use behavioral learning in your scenario. Okay, coach towards self-management. This is very important. Self-management, less passive approach. Okay, address comorbid health factors. Okay, this is also very important. Okay, is there any change in movement when back pain changes? Okay, you can search for Worley et al. Yeah, 2019. Yeah, they did a systematic reviews there. What they found was, okay, when there is increased range, it helps you to move faster. Okay, and it will cause more muscle relaxation, and definitely it will improve pain, yeah, and also increase activity, yeah. And future research show high quality design with repeated measures, because there are, you know, from their studies, they found that most evidence was very low in quality. So a lot of study need to be done, yeah, with high quality design, so that you can see, yeah, any changes in the range, yeah, related to the issue. Okay, what is the best evidence rehab, yeah, for chronic low back pain? All right, what is not good? Okay, if exercise or active management has showed good evidence, yeah. Examples of those are exercise therapy, any kind of exercise therapy, yeah, and also exercise therapy plus the psychological component, which is CBT, plus the pain neuroscience education, plus spinal manic therapy. Okay, but what are not good? All the passive management, all the electromodalities, yeah, the back school, yeah, education, yeah, and they recommend that choose exercise in line with patients' preferences and abilities, combine exercise interventions with psychological component to obtain better and longer effects. Okay, education is another part, another important part. Yeah. Okay, listen and connect. Okay, give time and space for your patient to tell you the story. That's why you have to ask open-ended question when you ask for social history, and also, you know, for the history. Okay, reassurance. Okay, again, sore, but it is safe. Okay, debunk all the myth. List, for example, you have to provide, you know, the accurate info to your patient. Live in a natural way. Okay, spines are inherently strong structures. Imaging is only one part of the picture. There are other further investigations. Yeah, limit bed rest, remain active and stay at work, explore movement and life. Yeah, move as much as you can. Yeah, aim for fearless, thoughtless movement based on preference, cause and access. Okay, home message. Yeah, you must understand of chronic low back pain versus the acute low back pain. Always include biopsychosocial approach in your management. Patient education is very, very important. Yeah, active approach must be used in chronic management. Okay, chronic low back pain management. Self-management approach and also combined therapy is very, very useful. Okay, here are the references that you can search around later to get the info. Thank you very much. And now is the
Yes, thank you very much, Dr. Zarina. Now we will move on to the question and answer session. Thank you for your very interesting and very informative sharing sessions.
You're very welcome.
Okay, let's look at the chat box. The first questions we have from Norfa Ain. Is it true epidural injection can cause back pain, Dr. Zarina?
All right. epidural injection when you want to undergo cesarean section, yeah, or any some other operation. Well, I have experienced this, okay, during my third delivery, and I found that it is not exactly causing the pain, okay. The thing is that most of the time when there is injection over that particular region, what did you do? Okay, do you have something in your mind, isn't it? Oh yeah, that area is injured, so I cannot move. Yeah, I cannot move as active as before because of operation and also injection there. Okay, bear in mind when there is any injury onto any structures in our body, definitely there is impairment there. Okay, so you need to do something to overcome that impairment. Okay, because of less movement, yeah, because of pain, so you do not do the activity well as good as before, yeah, it will cause further impairments onto the muscles especially. Okay, so your muscles become weak, especially the back muscles, the erector spinae there, and also onto your abs, because of you have cesarean sections, can, yeah, so you have multiple it's like a corset weakening there, yeah, so that you it will trigger to you the pain kind of thing. Okay, but if you have a good exercise, okay, especially the core muscles, okay, to overcome this corset mechanism, yeah, I think, yeah, your pain won't be there, yeah, with a good exercise, with a specific focus exercise, yeah, it helps to diminish the symptoms and improve your condition well. I hope it really answer your question.
Thank you, Dr. Zara. Yes, we do hope that that answered Norfa Ain questions. Okay, we have second question coming from Nazim Soleh. If the patient under the red flag, does it affect his or her progression in recovering from low back pain, Dr. Zarina?
Oh yes, thank you very much for the question. Yes, definitely yes. Okay, why? Okay, serious red flags. Okay, you must know what you can do and what you cannot do. Okay, most of the time, if you find that, oh yeah, very serious issue here, please, please, please talk to the specialist in charge or the doctors in charge. Okay, ask them about the scenario. Okay, ask them about the pathology of that red flags. Okay, you must also understand well, okay, in terms of their disorders, okay, their problem. Okay, discuss with them how should you manage, how far that you can go, okay, to intervene or to improve the patient's condition, in what sense. Okay, and you cannot work alone. Okay, in overseas and even here, yeah, if you have any patients with red flags, you have to to note onto patient's file that this patient is having red flags, so that other people that taking care of this patient, yeah, because you know that you are not taking care of this patient all the time, someone else may look at him or her later. So please take note of this red flags issue, notify and highlight what are the problems, what are the do's and what are the don'ts that you should do and you shouldn't do, what are the precautions that you need to take care of when you deal with these red flags people.
Yes. Okay.
All right, and again and again, okay, I keep reminding you, when you see any red flags patient, please have have a good discussion with the MDT, multidisciplinary team. Okay, because you cannot work alone. Okay, all right, thank you very much, hope this helps. Yeah.
Okay, thank you, Dr. Zarina. I think we have two more questions from the chat. The third question come from Nur Salvia. Hi, Dr. Zarina. Does pain education will help in management of chronic low back pain?
Oh, yes.
self-management, I think.
Yes.
Pain
Thank you,
education.
Salvia. Okay, thank you, Salvia. Hi to you. Yes. Yeah. Pain education is very important. Okay. I have followed mostly the studies by mostly since 2003, 2003. Yeah, at that particular time, there's a lot of research on neurophysiology education, yeah, on pain, yeah. In there, yeah, yeah, during that particular time frame, yeah, a lot of strategies, a lot of cue on neurophysiology pain education has been has been developed, and they do a lot of tests here and there. There's quite a number of clinical trials, yeah, by mostly at all, yeah. And even nowadays, yeah, you can see that a lot of Australian researchers and also UK's researchers, yeah, use that neurophysiology education on pain, yeah, to educate patients with chronic low back pain. And not only for chronic low back pain, but in chronic pain people. Yeah, because in musculoskeletal, we know that there are numbers of people that having musculoskeletal pain, which are chronic, okay? And even nowadays, yeah, they there's quite a number of studies, yeah, on mind body fullness, okay? That's a kind of education as well as CBT approach. Okay, but in Malaysia we are not into that yet. Yeah, probably, you know, in future. Yes, we are trying to work on that too. Yeah. All right. Hope that's answer you. Yeah.
Okay, Dr. Zarina, I think it is an interesting topic. I can see that a few more questions coming out in the chat box. Unfortunately, due to our time limitations, I will just pick one more question, and then
Sure.
I hope that maybe after that you can attend this question in the chat box. Yeah.
All
Okay.
right.
In your opinion, should chronic low back pain patients refer to multidisciplinary approach rather than physiotherapy alone itself, such as occupational therapy and psychology? Thank you.
Yes. Yeah, thank you very much for the question. Yes, definitely. Again, remember, you cannot work alone, okay? Especially in those people that having yellow flags kind of condition, okay? Chronic low back pain, there are multiple factors that leading to their problem. It's not solely on the physical matters, okay? If it is physical matters, yeah, and if it is only the biological structures that involve, yeah, maybe you can help 100%. However, in this chronic pain patient, bear in mind, it always involves psychological, it always involves social problem, yeah. So you need to encounter, you need to ask, okay, other group of people, yeah, to come together with you to help, okay. You need the social workers to work together with you. You need the clinical psychologists to work with you. You need the OTs to work with you, especially in terms of stress management. But if you are good in stress management and you can help the patient, yeah, you can do. But we are not so good in that stress management. Okay? So we need other people to help. It must work in a multidisciplinary approach. Yeah. Remember the yellow flag kind of people? Yeah, those people that really likes to go to your department for long, long time, more than a year, more than 6 months, more than 2 years, yeah. After has been discharged by you, then they come with a new referral again and again, again and again with the similar condition. Bear in mind, this is not physical problem. Okay, this is more than that. Okay, all right. Hope that answer you.